him. Uh, Throughout the 50-year history, Medicaid has been an adaptable, efficient program that meets the health care needs of millions of children, pregnant women, people with disabilities, seniors, and low-income adults. Today, Medicaid serves as a lifeline to nearly 72 million Americans who depend on the program for health coverage. The Affordable Care Act included the most significant changes to the program since its creation. It expanded coverage, made improvements to promote program integrity and transparency, and advanced delivery system reform. Thanks to these provisions, the uninsured rate is at a record low. The program continues to efficiently provide coverage to enrollees. Program integrity provisions of the ACA marked a shift from the traditional pay and chase model to a preventative approach in which fraudulent actors are kept out of the program before they commit fraud. Today, we are examining 6 Medicaid proposals. Efforts that truly improve transparency and program integrity are something I think we all can support. The Affordable Care Act took major steps to improve program integrity in the Medicaid, including new protocols for screening of suppliers and providers and additional authority to terminate entities that commit fraud. These are significant steps forward. However, more can be done to ensure these reforms are fully implemented. We should also continue to examine other ways to further strengthen Medicaid for all beneficiaries so that dollars are spent on quality care without inappropriately limiting access. While we hear from all 6 proposals during today's hearing, I want to take the opportunity to highlight 2. Prior to the passage of the ACA, if a state terminated a provider's participation in its Medicaid program, the terminated provider could potentially participate in a program of a different state. In case of Texas, they would probably come to Oklahoma and vice versa, leaving the system vulnerable to fraud and abuse. The ACA took steps to prevent this from happening, but OIG has identified weaknesses in that process. One of the legislative proposals will build on the ACA with some technical changes. The proposal would achieve its intent to further reduce waste, fraud, and improve quality and safety in the Medicaid program, something, again, we can all support. I'm concerned that 2 bills under consideration would scale back Medicaid eligibility under the guise of closing loopholes. The Affordable Care Act established a streamlined, coordinated eligibility determination system for Medicaid and CHIP, as well as premium tax credits and cost-sharing subsidies. The approach was designed so that people can qualify for the appropriate program without gaps or duplication and move between insurance programs when their incomes change. H.R. 2339 would undermine this by requiring states to count lump sum income as though it were income that the individual is receiving for up to 20 years after it's actually received. The bill is being described as a way to prevent people who win large lottery payouts from receiving Medicaid, but this is misleading. By counting all lump sum income as monthly income, the overwhelming majority of people would affect all those who receive things like workers' compensation settlements, unemployment, retroactive disability payments. If 2339 became law, a significant number of low-income Americans who receive lump sum could be inappropriately determined ineligible for Medicaid and lose access to their health insurance. Coverage gaps due to temporary changes in income are bad for patients, providers, and health plans, and ultimately is a waste of taxpayer dollars. This is a concept MACPAC has recommended in several reports to Congress. Gaps in coverage is an issue that I've been concerned about for years. For the last several Congresses, I have worked with my colleague from Texas, Representative Joe Barton, to advance legislation to require 12-month continuous enrollment Medicaid and S-CHIP. Proposals that ensure federal and state taxpayer dollars are spent appropriately on delivering quality care and prevent fraud, waste, and abuse from occurring should be supported. Good program integrity holds all stakeholders accountable without unintentionally impeding the access. I look forward to working with my colleagues on the committee to further strengthen the Medicaid program in key areas and build on the success. And again, I'd like to thank our witnesses for being here today and look forward to the discussion on the legislative proposals under consideration. And I yield back.
Chair, thanks, gentlemen. Now I recognize the Vice Chair of the subcommittee, Mr. Guthrie, 5 minutes for his opening statement.
Thank you, Mr. Chairman. I thank you for yielding time. I appreciate the committee holding this hearing on efforts to strengthen Medicaid by reducing waste, fraud, and abuse. In doing so, we can ensure the program's longevity and effectiveness. Earlier this year, I introduced H.R. 2446, which would require states to put in place an electronic visit verification system for personal care services. Medicaid personal care services are becoming increasingly more important as the need for them continue to grow. However, there is also growing concern about the high levels of improper payments in this area. My bill will help address these concerns by requiring states to adopt an EVV system to verify the date, time, and site of visit, as well as the provider of the services. This is critical to ensure that beneficiaries receive the services they need. Many states already operate EVV systems, and they have seen a decrease in improper payments and significant cost savings for the states. I want to thank the subcommittee for holding this hearing, Chairman Pitts for including it in today's hearing. And by strengthening Medicaid, we can ensure those who need it can rely on it in the future. And I would like to yield time to my friend from Florida, Mr. Bilirakis.
Thank you. Thank you, sir. Appreciate it very much. And thank you, Chairman Pitts, for holding the hearing. Earlier this year, I, along with the delegates from all the territories, introduced the Medicaid and CHIP Territory Transparency and Information Act, H.R. 1570. CMS reports Medicaid CHIP data for all 50 states and the District of Columbia, but not the territories. 3 months after introduction, CMS has started to report Puerto Rico data, but not the other territories, and the level of data is less than what is reported for states. My bill will require CMS to provide the same data for the territories as it does for the states. Puerto Rico's Medicaid program is facing some huge problems over the horizon. As a committee, we have to make some big policy decisions, and regardless of your policy views, we have to have all the data, all the information to understand the problem and exercise proper oversight over their program if we are to attempt to address these problems going forward. So thank you very much for the time, and I yield back.
Chair, thanks, gentlemen, and now recognize the ranking member of the full committee, Mr. Pallone, 5 minutes for an opening statement.
Thank you, Mr. Chairman, for convening this hearing on the 6 pieces of legislation before our committee. I'm pleased to see that some of the bills we're considering here today are true efforts to improve program integrity in Medicaid in ways that will strengthen the Medicaid program. That is a longstanding priority of mine, and there's still some technical work to be done, but the draft proposal that would build on authority given to CMS and states to terminate fraudulent providers from the Medicaid program is a worthwhile policy. We need to do a better job in this area to make sure that providers eliminated in one state are no longer able to cross state lines and continue to be reimbursed for bad care for beneficiaries. And this legislation will do that, and I look forward to working with my colleagues on the proposal. The proposed legislation under consideration today that would encourage our territories like Puerto Rico to invest in the creation of Medicare fraud control units that are over the long term bring dollars back to beneficiaries is a no-brainer. I have to say, however, that another bill, H.R. 1570, requiring website information about the territories beyond Puerto Rico is a dramatic step, and I'd prefer to start first with a request to the agency for that information before enacting a law to that effect. While not harmful, this approach seems rigid and misguided. I appreciate the interest in cracking down on fraud in the personal care services and home and community-based care space. Ensuring beneficiaries actually receive quality PCS to which they're entitled is an issue of serious importance, and one that I look forward to working with this committee on further. HHS and the Office of Inspector General have published an extensive body of work examining Medicaid personal care services and has found significant and persistent compliance, payment, and fraud vulnerabilities that we'll hear about today. I have concerns about H.R. 2446 as drafted, however. I do believe this issue should be addressed and look forward to a thorough review and assessment of recommendations for improvement. Unfortunately, we aren't considering just program integrity bills today. The ultimate test for all Medicaid legislation should be to determine if the proposal supports overarching Medicaid objectives to strengthen coverage, expand access to providers, improve health outcomes, and increase the quality of care for beneficiaries. I believe that the majority of what we're looking at for program integrity in Medicaid today achieves these goals. However, efforts to scale back eligibility in the Medicaid program in any way is not program integrity, and it's not closing loopholes. Proposals like the one we have here today that purports to address the so-called plight of lottery winners in Medicaid, I think are completely unnecessary from a practical perspective. We have several checks in place, and states already have the authority they need. But far more concerning is that H.R. 2339 is not about lottery winners at all. It's about undermining the streamlined, coordinated eligibility approach the ACA established by allowing states to count lump sum income that an individual may receive as though it were income that the individual is receiving for 1 to 20 years after actual receipt. And by lump sum, we're not talking about lottery winners. We're talking about uncompensated care settlement payments, Social Security disability back pay. We're talking about eliminating coverage for up to 20 years for a child on Medicaid because they have a parent that finally got a break with a little bit of income from selling the family home. Proposals like these that would undermine the coverage for millions of low-income individuals, including some of our most vulnerable children and seniors, are punitive to beneficiaries. Reviewing our final bill here today, H.R. 1771, I'm pleased that perhaps we can have a discussion about long-term care insurance or the lack thereof. I appreciate this legislation's effort to ensure spousal impoverishment protections remain when one spouse must enter a nursing home. As many of you know, I was a strong supporter of the Class Act that has since been repealed, and I've called repeatedly for a real discussion about a long-term care benefit that a middle-income family can depend on to be there when they need it. We have no long-term care insurance in this country, and until we're ready to have a discussion about improving options in the long-term care insurance marketplace, I'm concerned about changes to Medicaid eligibility in this space, even for a very small amount of individuals. Mr. Chairman, I've said repeatedly that the Medicaid program is the bedrock of the nation's safety net. I take protecting Medicaid seriously, and I view some of the good program integrity proposals we have to consider here today as efforts to advance that goal. However, Medicaid is the lifeline nearly 72 million children, elderly, and low-income individuals depend on for health coverage, and I will never support a proposal that would take that coverage away. So I want to thank you again for calling this hearing. Look forward to working with you further to consider some of these initiatives, Mr. Chairman, and having a thoughtful discussion. Thank you.
The chair thanks the gentleman. That concludes the opening statements. As usual, the written opening statements, all members may be made a part of the record. I'd like to ask consent to submit the following documents for the record: letters from the Alzheimer's Foundation of America and Sandata Technologies. Without objection, so ordered. We have one panel today. I'll introduce them. And in the order of your testimony, thank you very much for coming today. First of all, John Hagg, Director of Medicaid Audits, Office of Inspector General, U.S. Department of Health and Human Services. Secondly, we heard from Mr. Mullen the introduction for Nik Gomez, Chief Executive Officer for Oklahoma Health Care Authority. And finally, Trish Riley, Executive Director of the National Academy for State Health Policy, Commissioner Medicaid and CHIP Payment and Access Commission. Thank you very much for coming today. Your written testimony will be made a part of the record. You'll each be given 5 minutes to summarize your written testimony. So at this time, Mr. Hagg, you're recognized for 5 minutes.
Good morning, Chairman Pitts, Ranking Member Green, and other distinguished members of the committee. Thank you for the opportunity to testify about the Office of Inspector General's efforts to reduce fraud, waste, and abuse, and to promote quality and safety in the Medicaid program. Protecting the integrity of Medicaid takes on a heightened urgency as expenditures and the number of beneficiaries served continues to grow. My testimony today focuses on 3 specific areas of concern that the OIG has identified to be problematic. First, terminated providers continue to participate in bill Medicaid. Second, there are inadequate safeguards for personal care services. And third, the U.S. territories lack Medicaid fraud control units. Prior to the passage of the Affordable Care Act, if a state terminated a provider's participation in its Medicaid program, the provider could potentially participate in another state's Medicaid program, leaving the second state vulnerable to fraud, waste, and abuse. To prevent this, states are now required to terminate a provider's participation if that provider is terminated in another state. The termination has to be for cause, for example, for reasons of fraud, integrity, or quality. Through our work, we found significant problems. Specifically, we determined that not all states submitted data on terminated providers, and that much of the data that was submitted did not relate to providers terminated for cause. We also found 12% of providers terminated in 2011 continued participating in other states' Medicaid programs. To further complicate states' ability to terminate providers, Many states do not require providers who participate via managed care to be directly enrolled in Medicaid. If a state is not directly enrolled a provider, it cannot terminate that provider, and it may not even be aware that the provider is participating in its Medicaid program. OIG believes that CMS should, 1, require states to report providers terminated for cause rather than leaving it as voluntary. 2, ensure that the information reported is uniform, accurate, and complete. And 3, require state Medicaid programs to enroll all providers participating in Medicaid managed care. Another problematic area within Medicaid is personal care services. These services allow many elderly people and those with disabilities to remain in their homes rather than being placed in a nursing facility. As more and more state Medicaid programs explore home care options, OIG believes it is critical that adequate safeguards exist to prevent fraud, waste, and abuse in personal care. Through our work, OIG discovered some payments for these services were improper because they were either not provided in accordance with state requirements, not supported by adequate documentation, billed during periods in which the beneficiaries were institutionalized, or provided by attendants that failed to meet state qualifications. Over the years, we have made a number of recommendations to CMS to address Medicaid's deficiencies within the delivery of personal care services, including requiring qualification standards for care attendants be consistent across states, requiring care attendants to be enrolled or registered with the state, and requiring dates, times, and attendance identities to be listed on Medicaid claims. Currently, none of these recommendations have been implemented. Another way the OIG helps protect the integrity of Medicaid is by overseeing the state Medicaid fraud control units. Fraud control units currently operate in 49 states and the District of Columbia, but none are in the 5 U.S. territories. The major barrier to establishing fraud control units in the territories is the nature of Medicaid funding. Unlike Medicaid funding for the states, the territories receive a capped appropriation and routinely use the full amount appropriated. This becomes a disincentive to allocate scarce Medicaid dollars to the establishment and operation of a fraud control unit. Legislation could remove the disincentive. This could be accomplished by exempting unit funding from the capped Medicaid appropriation. OIG believes that such a change would also be cost efficient, specifically in Puerto Rico, which has a total Medicaid enrollment of more than 1 million beneficiaries and is comparable to Medicaid enrollment of many medium-sized states. In conclusion, it is critical that we strengthen oversight to ensure that Medicaid funds are spent appropriately. Thank you for your interest in our work and for the opportunity to appear before you today.
Now recognizes Mr. Gomez, 5 minutes for your summarization.
Good morning, Mr. Chairman, Pitts, Ranking Member Green, and distinguished committee members. Good morning. It's an honor to share Oklahoma's perspectives and experiences on a critically important topic like program integrity in an ever-changing healthcare delivery environment. It's important to note that this testimony is that of only one state's program. It's not made on behalf of any of the other states or association. Equally important is the acknowledgement that solutions offered here are not to the exclusive benefit of Oklahoma. This testimony highlights and reinforces the need for state flexibility rather than uniform mandates. Oklahoma maintains a dedication of integrity in every aspect of our Medicaid program. Recent changes have included improving the process for determining member eligibility, provider contracting and enrollment, claims payments, medical necessity, asset verification, and service verification. Prior to the implementation of the Affordable Care Act, Oklahoma made investments toward developing the nation's first fully automated real-time online enrollment system. Currently, 2/3 of Oklahoma's applicants for Medicaid are received from a personal or public computer through our online system. When added to the benefit of our community partners, more than 99% of our applications processed in the community are processed in real time using a rules-based decision engine. In addition to relieving a tremendous administrative burden, this system allows for real-time enrollment while strengthening the state's ability to verify reported information with various sources, including the Social Security Administration, Department of Homeland Security, and the Oklahoma Employment Security Commission. Oklahoma's pride is in its constant dedication to improving its program integrity is reflected in its payment error rate measurement. The payment error rate measurement program is an audit conducted by CMS on a 3-year rolling average to measure the accuracy of payments made for Medicaid-covered goods and services. The audit takes into consideration member eligibility, provider eligibility, and medical necessity. Oklahoma's most recent PERM audit identified a 0.24% error rate, 0.24%, amongst the lowest of the 17 states within the same cycle. Most states are around 9%. This success is a testament to the engaged provider services and training infrastructure, as well as Oklahoma's continual audits to using PERM criteria in the interim during in between PERM audits, something we're very proud of. Many of the issues being addressed in the upcoming hearings are issues that Oklahoma is facing or has attempted to address in the past. One issue in particular we have attempted to address on our own, and now with the help of Congressman Mullen, we're able to address in H.R. 1771. Since its creation, the statutes and regulations governing Medicaid program have been amended numerous times and now consist of a complex interrelated provisions that are often difficult to understand. One such area surrounds standards to prevent spousal impoverishment. Medicaid statutes allow the spouse of a Medicaid applicant for long-term care to keep a certain amount of his or her resources so that he or she is not required to become impoverished before their spouse can receive long-term care. Unfortunately, individuals are now using court-recognized loopholes to transfer significant resources to a spouse, transfers that would normally disqualify them from Medicaid. States have denied applicants who are clearly above Medicaid's income standards or resource limit standards, only to have the court orders the approval of such applications as a result of certain estate planning loopholes that they are recognized to contrary to Medicaid's intended purpose, but can only be corrected by Congress. In an attempt to curtail the practice, Oklahoma denied such an application using this loophole that resulted in the Morris v. Oklahoma Department of Human Services. Morris is the seminal 10th Circuit decision which directly impacts not only Oklahoma but 5 other states in the circuit, and also has been extended and relied upon in at least 3 other federal circuits and several state courts. The court's ruling essentially permits a married couple to shelter potentially unlimited amounts of assets through the use of non-assignable, transferable annuities in order for the spouse in need of medical care to qualify for Medicaid. In reversing the district court, the Court of Appeals stated, although we understand the district court's concerns regarding the exploitation of what can only be described as a loophole in the Medicaid statutes, we conclude that the problem can only be addressed by Congress. The passage of H.R. 1771 would be a needed step towards preserving shrinking resources that would help empower states to ensure those applicants truly in need can still access quality services. I would like to thank Congressman Mark Wayne Mullen for agreeing to working with the states to remedy this and look forward to working together with the committee. With that, I conclude my remarks and happy to answer any questions.
Chair, thanks, gentlemen. Now recognize Mr. Riley, 5 minutes for your summary.
Good morning, Chairman Pitts, Ranking Member Green, and members of the subcommittee. I've served as a commissioner of MACPAC, the Medicaid and CHIP Payment and Access Commission, since its inception in 2010. As you know, MACPAC is a congressional advisory body charged with analyzing and reviewing Medicaid and CHIP policies and making recommendations to Congress, the Secretary, and the states on issues affecting these programs. I am one of 17 members appointed by the GAO. While I'm also Executive Director of the National Academy for State Health Policy, my comments today solely reflect the work of MACPAC. We very much appreciate the opportunity to be here today as the subcommittee considers changes to the Medicaid program. The Commission shares the subcommittee's interest in ensuring federal and state taxpayer dollars are spent appropriately on delivering quality, necessary care and preventing fraud, waste, and abuse from taking place. When designed and implemented well, program integrity policies and procedures should ensure that eligibility decisions are made correctly, prospective and enrolled providers meet federal and state participation requirements, services provided to enrollees are medically necessary and appropriate, and provider payments are made in the correct amount and for the appropriate services. The Commission has identified and shared with you through our reports to Congress a number of challenges associated with implementation of an effective and efficient Medicaid program integrity strategy, including overlap between federal and state responsibilities, insufficient collaboration and information sharing among federal agencies and the states, diffusion of authority among multiple federal and state agencies, lack of information on the effectiveness of program integrity initiatives, and appropriate performance measures. We also identified concerns about lower federal matching rates for state activities not directly related to fraud control, incomplete and outdated data, and few program integrity resources for delivery system models other than fee-for-service. Specifically, the Commission recommended that the Secretary of HHS should collaborate with states to create feedback loops to simplify and streamline program integrity requirements, determine which current federal program integrity initiatives are most effective, and take steps to eliminate programs that are redundant, outdated, or not cost-effective. In addition, in order to enhance states' abilities to detect and prevent fraud and abuse, the Commission has recommended that the Secretary should develop methods for better quantifying the effectiveness of program integrity activities. The Secretary should assess analytic tools for detecting and preventing fraud and abuse and promote the use of those tools that are most effective. In addition, the Department should improve dissemination of best practices in program integrity and enhance program integrity training programs. The measures before the subcommittee today also speak to other policy objectives of interest to the Commission, including simplification, transparency, and the alignment of policies across federal health programs. Even so, I want to clarify that MACPAC has not reviewed nor expressed its views on the merits of the 6 specific initiatives that are the focus of today's hearing. My written statement provides technical comments on the potential implications of these proposals and issues that could be addressed as the subcommittee considers them. Again, thank you very much for this opportunity to appear before the committee, and we would, of course, be happy to provide technical information from the staff or to answer questions today.
Chair, thanks to the gentlelady. That concludes the opening statements. We'll now begin questions, and I'll recognize myself 5 minutes for that purpose. Mr. Hagg, the U.S. territories are already required by law to have a Medicaid fraud control unit. Is that correct?
I believe that is correct, yes.
Given that, can you explain why the territories do not already have such units and how H.R. 3444, the Medicaid and CHIP Territory Fraud Prevention Act, would encourage their creation?
Yeah, yes, I think it has to do with, why they don't have fraud control units now has to do with how their Medicaid programs are structured, or the funding of those programs are structured. In the territories, the Medicaid programs are capped, unlike the states where it's open-ended. To create a fraud control unit, the funding that it would take to start up the unit and then to operate the unit would take away from trying to provide for services for bennies in the territories. I think that's a difficult decision for them, taking away funds that could be used to provide services. The bill will move the funding that would be required to run the fraud control units out of that capped amount. And so it should take that disincentive from expanding a program or creating a program away.
Thank you. And Mr. Hagg, your work found that the lack of uniform terminology for the reasons for provider terminations caused challenges for state agencies. Can you please explain the challenges created, how the policy we're discussing today could help resolve those challenges?
Well, as far as uniform terminology, we performed 2 studies involving terminated providers. The first was looking at the action CMS had taken to create a central data system that would house all of the providers that had been terminated. In looking at that data set, we found some states didn't submit any data at all. We found some states that submitted data. The data wasn't complete. They were missing maybe, like, say, an address for the provider. And then as far as uniform terminology, we found that some states were submitting providers that had been terminated for reasons other than cause, reasons other than fraud or integrity or abuse issues. So say, for example, in a state, if they terminated a provider because of billing inactivity, some states would submit that information to the central database. Other states potentially could look at that database and say, we need to terminate that provider as well, even though there wouldn't be a reason to. So only providers terminated for cause should be submitted to that central data system, not other ones. And so uniform terminology or guidance provided by CMS about uniform terminology could help correct that issue.
Mr. Gomez, according to the GAO, some states have indicated that the use of annuities as a Medicaid planning tool have increased in recent years despite congressional action, most recently as part of the Deficit Reduction Act, to eliminate this loophole. Has Oklahoma seen an increase in the use of annuities in recent years, and if so, why do you think this is the case?
Mr. Chairman, thank you. Yes, we have seen an increase in the number of annuities as quite frankly, families have found ways to avoid the 5-year look back on income and assets, and it's allowed also a growth in the number of promissory notes too, which this amendment doesn't deal with, but it's a growing issue where we've allowed the annuity to be able to shelter assets, so the spouse can, in the community, the spouse and the institutionalized spouse will be able to qualify for the program when the assets are there to be able to help pay for the services provided.
Mr. Gomez, do you think it's appropriate for millionaires or multimillionaires to be receiving Medicaid while at the same time there are disabled children on the waiting list for home and community-based services?
And that's why we're here, Mr. Chairman, is because we have, in Oklahoma, have cut the program hundreds of millions of dollars over the last couple of years, and every time we cut the program, we recognize that there are potential families that are getting access to the Medicaid program who would not financially qualify. So to answer your question, no.
So if I told you that states are barred from disenrolling multimillionaire lottery winners from Medicaid, I would assume that you would find this troubling, yes?
I would find that troubling, yes, sir.
Furthermore, while the federal government is paying 100% of the cost of Medicaid expansion, including the medical bills of millionaire lottery winners, there are disabled children and HIV patients on waiting lists for some Medicaid programs. So do you think it is fair to use Medicaid dollars to pay for lottery winners?
Well, the purpose of Medicaid is to provide coverage for low-income families and other categorically related individuals who meet certain eligibility requirements. And it's an income-based program, so it's very difficult to make an argument for anybody above a low income.
Can you explain how it is that Medicaid policy permits million or multi-million-dollar lottery winners to retain Medicaid coverage when they can clearly afford to purchase their own health insurance?
Well, the way the system is set up now through Medicaid is we look at eligibility on a month-by-month basis, so we're not able to look at it so a person could receive a lottery winning within a given month and then come back and reapply the next month and be qualified for the program, which I don't believe that was the intent.
I recognize the ranking member, Mr. Green, 5 minutes for questions.
Thank you, Mr. Chairman. Mr. Gomez, how many how many people receive Medicaid in Oklahoma on any given day?
Over a given course of a year, we'll serve about 1 million Oklahomans. Oklahoma only has about 3.6, 3.7 million Oklahomans, so more than 25% of our population is utilizing the Medicaid program in a given year.
How many people have you identified that are either are using the lottery exception or even the annuity in Oklahoma? Do you have a number?
I don't, Mr. Chairman, Ranking Member Green, I do not have a number, but I'm happy to provide that to the committee for the record.
Do you think it would be more than 100 out of the million people?
I would really hesitate to speculate, okay. But I would be happy to.
I'd love to see that information because I'd like to see, you know, obviously we want folks who need the program to get it, but if we also throw up some impediment, we may end up excluding people who really do need it. But again, thank you. One of the reasons the Affordable Care Act changed from the previous asset test Medicaid into the current modified adjustment gross income formula is to streamline and coordinate eligibility between Medicaid and health insurance marketplaces. Ms. Riley, can you describe the complexity of the implementing this legislation for purposes of keeping coverage streamlined and coordinated? Do you think the legislation moves us backwards in a patchwork system where we would potentially have 50 different rules for eligibility?
Well, I understand the complexity of wanting to be sure that we have a quality, affordable health care system and that we have investments in coverage that are appropriate. That said, there's been enormous undertaking in the states to try to, through the Affordable Care Act, to try to integrate the eligibility systems between the federal marketplace and between Medicaid. And I think given states' options to change some of that, that could certainly make more complex.
Would this potentially create additional cost at the federal level, in particular with the federally facilitated marketplaces in 37 states?
I think it could. Again, this would be a state option, so it's unclear how each state would tweak their eligibility determinations, and as such, when there has to be an integration with the federal marketplace to try to streamline and make eligibility smoother and simpler, it would require the federal marketplace to have to make a tweak to its federal system that's now one system with the states for each change that every state makes.
Okay. Is it correct that I'm reading the legislation as potentially applying to anything such as Social Security, disability, back payments, workers' compensation, or any amount at all, and the state would prorate the amount monthly for up to 20 years, even if you no longer have access to those funds? Okay.
I
Would,
didn't hear the end of the question, I'm sorry.
would this legislation potentially applying to Social Security, disability, back payments, workers' compensation, or any amount at all that the state could prorate that would amount to monthly up to 20 years, even
yes.
though it's not available to them over that 20 years?
Yes, it's my understanding of the bill that it would do just that, and that the lump sums can be certainly we all appreciate the lottery issue, but lump sums could be SSDI payments, disability payments, and other.
Okay. We have a lot of program integrity bills that we're considering today that are focused on niche areas. I want to take a step backward and look more globally at the landscape of the program integrity in Medicaid. Can you describe MACPAC's work on program integrity to date?
I can. We have taken a very serious look at program integrity, both in our March 2012 report and our March 2013 report to the Congress, particularly where we've seen a real complexity in program integrity, where there are multiple state and federal agencies that have various aspects of program integrity. Department of Justice, numerous Health and Human Services agencies, state governments, often competing, often redundant, and we have suggested that there's a real need to streamline those activities, to look where there's redundancy, and to find out where the best practices exist among the states. Importantly, we invest in Medicare fraud control units with a 75-25 match. We do not invest in other activities states need to undertake to prevent fraud at that same level, notably the administration of the program.
Okay. Thank you. Mr. Chairman, I have some other questions I'd like to submit to Ms. Riley on highlights, low matching rates for activities not directly related to fraud control and things like that. But I appreciate MedPAC's reports, and hopefully Congress can act on those, both to save federal money, but also, because in Texas, our match, it's about 65% federal, about 35% state, and somewhere along the way, we need to match that. We want the state's participation, but we also want to make it to where we can get that fraud that we're looking at. So thank you, Mr. Chairman.
Chair, thanks, gentlemen. We'll submit the follow-up questions to you in writing. We ask you to please respond. Chair, I recognize the Vice Chairman of the Subcommittee, Mr. Guthrie, 5 minutes for questions.
Thank you, Mr. Chairman. I appreciate that very much. And first, I have a unanimous consent request to enter into the record a letter from ResCare.
Without objection, so ordered.
Thank you, Mr. Chairman. This is a question for Mr. Hagg. We agree it's important to ensure that patients receive the services they're supposed to and that taxpayer resources are protected. And in that vein, I introduced H.R. 2446, which would require states to use electronic visit verification for personal care services under Medicaid. So I'd like to discuss some of the work your office has done in this area of fraud and abuse of personal care services. In 2012, in your 2012 portfolio report on personal care services, you outline a series of audits that were done in 8 locations, 7 states and in 1 city, that identified over $582 million in questionable costs. There was a wide error rate from 0% in one state to over 40% in another. Can you walk us through some of the issues you found in those audits and what were the most frequent problems you saw?
Yeah, I'd be glad to. The main issues we found were providers submitting claims that didn't follow all of the federal and state requirements. Some examples would be just across the board, qualifications of the attendants not being met. Things like background checks, specific training, things like that. We found that proper supervision wasn't provided. There's a certain level of supervision for the attendants, and in some cases it wasn't always met. We found instances where physician approval or authorization hadn't been set up for the services to be provided. We found instances where plans of care hadn't been approved or set up. Other cases where there was just a lack of documentation. Without the documentation, you can't tell if it's just sloppy record keeping or if a service was never provided. We found a lot of instances where there were beneficiaries. We had a bill for a specific beneficiary, yet we knew from data match that beneficiary was in an institution, a hospital or a nursing home at the same time. Those are the main type things. I mean, there's a lot of different errors across the board, a lot of high error rates, a lot of dollars, as you point out. But those are, I think, the main buckets of the problems that we found.
Okay, thank you. Your report also outlined a number of concerns about quality of care for beneficiaries receiving personal care service due to some of these problems. Can you outline how the Medicaid beneficiary suffers because of some of these instances?
Well, the quality of care issues that came out of those reports, what we tried to do in a lot of those audits, not in every one, but in a lot of them, we tried to interview the beneficiaries receiving the services. And a lot of the responses we received back had to do with the attendant stealing from the beneficiary or abusing them, threats of abuse. I think there were cases of abandonment where the attendant would be out shopping for groceries or something with the beneficiary, and they would say, "It's my shift is up. It's time for me to go," and they would leave them there. Those are the types of quality type issues that we mainly identified.
Okay, thank you. And then the electronic visit verification systems provide information on the date, time, duration, location of service, as well as the type of service performed. How do you think the availability of such information will help minimize the problems you identified?
Well, I think it would help. Of the problems that I've laid out, some of them I don't think would be addressed by the electronic visit verification, but some would. When you have cases of lack of documentation, I would think EVV would help clear that up. You're either providing the service at the location or you're not. The same thing with beneficiaries who are in institutions at the same time we're receiving a bill, at the same time, the same thing for when we have a timesheet of an attendant that says they were at a different location, yet we have a bill for somebody else. I think EVV would help or may help address those type issues.
Well, thank you. Those are my questions. I yield back my time.
Chair, thanks, the gentleman. Now recognize the ranking member of the full committee, Mr. Pallone, 5 minutes for questions.
Thank you. I understand that we have a piece of legislation here to tighten up eligibility in the Medicaid long-term care space, and I think this bill has been drafted in a way that is careful, unlike the other eligibility legislation under consideration today, and it's drafted to guard against unintended consequences that can be harmful for beneficiaries. However, I still remain concerned about tightening eligibility in Medicaid when overall we have no other alternative for people of low and moderate income to invest in long-term care planning so that a long-term care benefit is there for people when they need it. But before we start tightening up on Medicaid, we need to have a real conversation on long-term care in this country so that we don't take away the lifeline for people without having any other options in place. The reality is that this legislation would change the historical consideration of a spouse's income as separate, and that is a big precedent to set in the absence of long-term care reform in this country. In addition, I understand that income and resource counting and the various eligibility pathways for long-term care in the Medicaid program are incredibly complex already. But Mr. Riley, I know that MACPAC has done a fair amount of work in Medicaid, so can you give us an overview of the Commission's work on long-term care and any recommendations you have in that regard?
I'm very happy to. Obviously, this is an area of great concern for the Commission, given that Medicaid does pay, as you say, 61% of all the long-term care costs in the nation. And on the converse, to the point of the cost effectiveness, while long-term care clients represent about 6% of users, they use 51% of Medicaid dollars. So it's an area of great concern to the Commission. To date, we've looked and have reported to you about the managed care initiatives in long-term care, at rebalancing between home and institutional care, and about the data needs that we really have to address to be able to address some of the broader issues. On our plate for future work is to look at the merits of standardizing functional assessments about who gets into coverage, to look strongly at the quality measures in long-term care, to focus on housing and assisted living, and particularly to look at how the new Medicaid managed care regulations may impact efforts to manage care and long-term care.
And I understand you used to be the Director of Aging in Maine. What areas or recommendations can you share for our consideration based on the challenges that you encountered in your operational experience?
That was, I'm aging in place. That was a very long time ago.
But we're all aging in place.
I think the tragedy is that we still have a situation where in this country, the majority of long-term care services are still paid for by Medicaid. We had hoped 30 years ago that might not be the case, and that Medicaid remains a critically important provision. I think way back in those days, we were just beginning state recovery efforts, which relate very much to the work here. Very important efforts to make sure Medicaid is spent properly and efficiently and effectively. And I think what one learns running the programs is the devil is always in the details. It's very difficult to think about how to implement these kind of programs, and one needs to think about all the alternatives and the administrative demands and the costs of those and weigh those against what the benefit will be.
I mean, I could just say, I guess many people probably already know this, but I just hate the whole spend down provision. I just think it's awful. I'm so tired after 27 years in Congress of having these people call up my office who are involved in spend down and all the, terrible implications of that. And I would really like to see, I mean, I know, not to take away from the chairman or our Republican colleagues, I mean, I know they're not going to, be in favor of some kind of new Medicare benefit for long-term care, but I really think we really need to do that at some point, because the way we operate, where we make people spend down and then go on Medicaid, it's just, I can't imagine I've never looked, but I can't imagine any other country in the world operates that way. It's just the most stupid thing to do. And availability of long-term care insurance is very, very limited. If anything, it seems like it's more limited. And I know that when we did the Affordable Care Act that, we were subject to certain spending limitations, and so we really couldn't address this. We tried to do the Class Act, and that got repealed with regard to, community-based care. But for institutional care, we just can't continue to operate this way. And I just hope at some point, Mr. Chairman, even though, there may be Republican opposition, that we can have some kind of hearing or deal with this larger issue of paying for long-term care in a different way than we do. So thank you very much.
Chair, thanks, gentlemen. Now recognize Dr. Burgess, 5 minutes for questions.
Thank you, Mr. Chairman. I'll try to find a microphone where I can actually see the panelists. It may be difficult, so I apologize if I'm talking to you through someone. Okay, Mr. Pallone brought up some points and actually used the debate to say that Republicans were not interested enough in long-term care. Look, I haven't been on this committee nearly as long as Mr. Pallone. I will, in no universe, be able to spend the amount of years on the committee that Mr. Pallone has spent. But I do remember the Deficit Reduction Act of 2005. And we talked at that time about things we might do to get people interested in purchasing long-term care insurance who could afford it. And that was met with a lot of resistance. Now, I buy my health insurance in the individual market, and as a consequence, I pay for that with after-tax dollars. So those are really expensive dollars to have to spend. And we do the exact same thing to people who want to provide long-term care insurance for themselves or their families. They pay for it with after-tax dollars, and there has been an absolute stone wall of providing any type of recognition that this is a benefit or this is an activity that we would like to encourage people to do. I can think of no more loving gift that a parent can give to their children than to carry long-term care insurance so that they, the parent, are not a burden to their children. Not everyone can afford long-term care insurance. I understand that. I pay for a policy myself. I understand how the policies are sometimes difficult to find, and yes, they can be expensive. We've made that harder. We made that harder with the Affordable Care Act, with the Class Act provision that was thrown at the last minute. Very little consideration, no hearings, no evidence collected, and as a consequence, companies that were involved in providing long-term care insurance, because the assumption was then made that, hey, The Affordable Care Act is now taking care of long-term care insurance when it wasn't, and we had to abandon the provisions of the Class Act because they were so bad and a classic insurance death spiral that now people are in fact left with less than they had before. So I apologize, I didn't mean to go off topic, but I felt that there needed to be some counterbalance to that debate. Now, since I'm off topic already, let me stay off topic. Mr. Gomez, your governor, Mary Fallon, who served with us here in the House of Representatives several years ago, and we miss her, but we do value her service to the people of Oklahoma as their chief executive. She signed a bill last March or April that was a requirement for prescription drug monitoring, the requirement for physicians to check against a database before prescribing certain drugs. We've had, I don't know how many hearings this year in the Health and Oversight subcommittees on prescription drug abuse. And we go back and forth with the prescription drug monitoring issue, but you guys solved it in your state when Governor Fallon signed that into law. Well, it'll go into effect, I guess, in November, so you haven't quite solved it yet, but you're on the road to doing that. When Governor Fallon was at the National Governors Association meeting this summer, and Secretary Burwell was addressing that meeting, she asked Secretary Burwell about would it be possible to require that same type of prescription drug monitoring in Medicaid. And I guess my confusion then is why is it does being on Medicaid somehow exempt someone from prescription drug monitoring? Or is it that this is such a good idea we ought to use it, since there is a federal jurisdiction for Medicaid, that we should apply it in a federal sense across the country? Can you clarify that for me?
Well, let me clarify about what's happening in Oklahoma is the Governor Fallon and that legislation has empowered the use of a real-time database that's available to physicians and pharmacies and for us in the Medicaid program to be able to monitor prescription drug abuse in the program. And it requires physicians to look at, when they make a prescription, to look and see if there's been some abusive pattern, physician shopping or ER diversion, something like that, to where they've been able to see it. So
right, we get that. We've authorized a monitoring program here in this committee. It's called NASPR. We're in a fight with the appropriators, so they've got their own. So, but is there anything that prevents Oklahoma from using the database for their Medicaid patients?
no, we actually have access to the database today.
So the same requirement that will be there for anyone else is there for Medicaid patients?
Yes, sir.
And this is, this is more than, this is an important point because, the CDC has already pointed out where the difficulties with prescription drugs are, expanding state expenses and federal expenses for prisons, jails, what have you, recovery programs. So it is extremely, if we want to talk about saving money in Medicaid, it seems to me this is one of the places where we should focus. Mr. Haig and Ms. Riley, let me just ask a brief question. The problem with third-party liability, a state that is paying a Medicaid bill for someone who actually has coverage from another insurance company, and there's a GAO report from now, it's over 10 years ago, and it's been very frustrating to me that this is a problem that cannot be fixed, but is the issue of somebody who's got coverage with a regular indemnity insurance plan, and yet the state is picking up the tab because that person is also covered by Medicaid. In other words, Medicaid should be the provider of last resort, not first resort. Can either of you address that?
Well, I'd be glad to try. Over the years, we've done a little bit of work involving third-party liability. Clearly there's probably more work that needs to be done. I know states go to great efforts through contractors and through their own staff to try to identify people on Medicaid who do have other insurance with data matches and others to try to recoup that money that they would have spent for those beneficiaries, or to try to prevent it from going out the door to begin with. I think states do a pretty good job with that, but just like anything, there's more work that needs to be done.
Not according to the GAO report, but I may talk to you more about that further because it's not an insignificant amount of money that we're talking about. It can be as much as 25% in some states. Thank you, Mr. Chairman. I'll yield back.
Chair, thanks, gentlemen. Now recognize the gentlelady from California, Ms. Capps, 5 minutes of question.
Thank you, Chairman Pitts, and also Ranking Member Green for holding this hearing. Our nation, and we have another topic that I think we need to address. I hope we can in terms of long-term health care needs. But our nation's Medicaid program is a critical safety net for all Americans who know that if they fall on hard times, they will not need to sacrifice their access to health care. The Affordable Care Act took great strides in streamlining eligibility to the program, ensuring that it would be there for those who need it. And many of these bills would help, that we're addressing today, would help strengthen this program further, and they should be supported. But I want to focus on one which I've heard here today, H.R. 2339, and I believe that is not one of these that should be supported. I'm curious about the situation of a young child whose parent may receive a lump sum payment. So to be clear, and I think this is common misperception, the parent receives the lump sum, but it is actually the child who is the Medicaid enrollee. And that's what the misconceptions are about. The Medicaid program, in this case, is for the child. As we all know, the majority of Medicaid enrollees are children, and this is followed closely by low-income elderly and by disabled individuals, with a very small proportion of parents and low-income adults rounding out the program. So, Ms. Riley, if a child's parent received a lump sum for any amount, $50,000 or whatever, and then, of course, that would be taxed, I'm sure, but the child is actually the Medicaid enrollee, would the bill be as drafted potentially count against the child's eligibility, not just 1 month, but from then on? How long? Oh, I'll let you answer that question or address it.
As I understand the bill, it would indeed have that potential, and our staff could certainly do some more technical analysis on that.
How long could that amount potentially count against the child's Medicaid eligibility?
If it was, as I understand the bill, if it was over $50,000, it could count for 20 years.
So that lump sum amount, no matter what the parent or adult spent it on, would make sure this child was not eligible for a very long time.
That would be how I would read the bill, yes.
So you're saying that it's possible this bill could be interpreted in a way that would cause a child to lose Medicaid eligibility for the rest of their childhood, even if the family's financial status were to change in the next 5, 10, or 20 years,
Yeah.
or even in the next month, because that lump sum is a precarious amount in some respects.
Right, and it gets stretched over months, yes.
Right. I think this actually as it's being interpreted differently by many, I find it very concerning in the underlying challenges, because it is, the truth is that H.R. 2339 could have many unintended consequences, consequences that could keep poor kids from care, really for their lifetime, and leave many others in limbo, because the eligibility isn't an overnight thing. So please, if comment, I have some other time, and this is the topic I wanted to address, if you'd like to make further statement about it.
I think that is a possibility. I think the definition is broad, and I think it would also depend on how each state would interpret it. So it also would be a variation in the program across states.
I see. So this is something that I can't support, and I hope my colleagues will reconsider if they are supporting it, because I think on the surface it may be seen very attractive, but underneath there are some unintended consequences that I think could be very harmful. And it goes back to the basic thought that it is the parents who receive the benefit, when it actually is Medicaid in most cases, in this case, are designed to benefit poor children and those with disabilities. Thank you. I yield back the balance of my time.
Chair thanks the gentlelady. Now recognizes Dr. Murphy, 5 minutes for questions.
Thank you, Mr. Chairman, and thank you, panel, for being here. I know as we're talking about the integrity here, one of the things we had a hearing on in our Oversight and Investigation Subcommittee, which I chair, was the idea that Medicaid has $17.5 billion in improper payments and maintains a high threshold of tolerance in that. I want to talk about one area where it's not just going after those who are being fraudulent, but a policy within Medicaid, and Mr. Hagan particularly, get your comments on this. In HHS's OIG report from March of this year was entitled Second Generation Antipsychotic Drug Use Among Medicaid-Enrolled Children, Quality of Care Concerns. I don't know if you're familiar with this report or not.
Not overly, no.
Okay, I'll give you some information on it.
Great.
They described in there that 8% of second-generation antipsychotics, otherwise known as SGAs, were prescribed for the limited number of medically accepted pediatric conditions. Only 8%. That means 92% of claims that were not prescribed for medically accepted pediatric indications were off-label. There's a quality of care concern that was identified in this report in medical records for 67% of claims for SGAs prescribed for children. And there was 2 or more problems for 49%. I'll read you one of the case studies. A 4-year-old child diagnosed with ADHD and a mood disorder, in which this was reviewed by a child and adolescent psychiatrist. They said there was no evidence in the child's medical history of any monitoring while the child was taking the sampled SGA. The reviewer stated that individual, family, and behavior therapy should have been attempted before initiating treatment with drugs. However, there was no evidence in the child's medical record indicating that such therapies were attempted. They also went on to say the child was prescribed 4 psychotropic drugs during the review period, of which 2 were antipsychotics. The reviewer noted that there was no appropriate doses prescribed for the antipsychotics in this child's condition, and the reviewer stated that the treatment with the SJ was not appropriate for a 4-year-old. Now, it made a series of recommendations. First, to work with state Medicaid programs to perform utilization review of SGAs prescribed to children. Second, CMS should work with state Medicaid programs to conduct periodic reviews of medical records associated with claims for SGAs prescribed to children. And third, CMS should work with states to consider other methods of enhanced oversight of SGAs prescribed to children, such as implementing peer review programs. Now, apparently CMS concurred with all these recommendations. Are you familiar with any of this, and do you know if any progress was made on any of these recommendations?
Unfortunately, I'm not familiar with that work. I'd be glad to take questions back to my colleagues at the OIG.
Would you
and they
please?
get back
Thank
with
you.
answers.
Are either of you familiar with any of this as state issues? Ms. Riley?
It's a very serious issue, and I know, I believe that's a report, Congressman, that spoke specifically to the foster children and their disproportionate use of these.
Yeah, there was, in 2011, talked to foster children. This looked at a wider range of kids, but yeah, you're right about that, too.
I know that MACPAC has taken that under very serious attention and is looking at, particularly around the focus on foster children, and we'll be getting a report to you sometime in the future.
So here's something I'm thinking for the states, and also with regard to your office too, sir, that we are all very concerned of people who are involved with waste, fraud, and abuse. But there's a Medicaid policy that says you can't see 2 doctors in the same day doctor rule. So if a pediatrician identifies, if a mother brings a 17-year-old to the doctor and says, I'm very concerned, my son is talking to himself, he's hearing voices, he's doing poorly in school, he's lost his friends, he's isolated, and that pediatrician rightfully says, we need to have you see a psychiatrist immediately. This is a very serious concern. Oh, you're on Medicaid? I'm sorry, you have to go home. This is the rule. And so what happens is, I wonder if this is perhaps one of the reasons why over 72% of antipsychotic drugs are prescribed by non-psychiatrists. Can you imagine the outrage if I said 72% of heart surgery is performed by people who aren't surgeons? And so what I see here is while people may be operating within the rules of Medicaid, it may be actually inviting these kind of improper cases. So when we look at what has happened in the past where this committee rightly has been concerned, 50 deceased providers and 50 providers who have been excluded from Medicaid and people with suspended or revoked license could all bill Medicaid. My concern is we have rules within Medicaid that says just because you have an MD or DO after your name, you can still prescribe. But we end up with what I think is a pretty amazing report from the Office of Inspector General saying something's wrong here. And I hope that this is something that states comment on and in your office comments on too, and recognizes that part of the problem we have here is to fix this. This committee, everybody in this committee knows we have to fix things in mental health. People have got some tremendous ideas and we want to do this. But I hope this is one of those areas that Medicaid can also review to fix this harm that's happening to our children. Thank you. I yield back.
Chair, thanks, gentlemen. Now recognize the gentlelady from Florida, Ms. Castor, 5 minutes for questions.
Thank you, Mr. Chairman, and good morning. Like many of the other members, I'm very concerned with the unintended consequences of H.R. 2339. Medicaid eligibility was recently updated, and it was tied to the modified adjusted gross income measure to streamline eligibility and prevent gaps in coverage. Now, H.R. 2339 proposes a surgical change in the law to prevent lottery winners from maintaining Medicaid eligibility, but as currently drafted, children and other individuals may be affected by the change. In MACPAC's relatively quick review of this legislation, can the Commission foresee problems with implementation and unintended consequences?
We have done just a very, we don't take positions on particular pieces of legislation. The staff has looked at this, and I think the concerns are around the definition of lump sum and the discussions we had earlier that, in fact, it could catch payments for a disability, for an accident where somebody has been paid a disability payment. We know that there's a 2-year wait for people for SSDI, and then there's often a lump sum payment for the person who may, in fact, have medical bills to pay. So I think the issue here would be the issue of how broad the definition is and how much
Right, so we have
sweeps
some
in.
work to do here. Many of the bills on the agenda today target provider fraud and individual eligibility. But I'd like to ask you all as experts, whose responsibility is it to enforce Medicaid and the Social Security Act statutes when a state does not follow the law? Mr. Hagen?
Well, CMS is responsible for the broad federal oversight of the program.
I know this probably has never happened in Oklahoma, but generally speaking, what's your answer?
Well, CMS as the oversight, and it's one of those things where we have auditors in our office every day looking at every aspect of the program, both federal and state level.
Okay.
CMS.
And can you give me an example where a state was in violation of the law under Social Security Act Medicaid statutes and they took action and addressed a situation?
Yes, a lot of the examples that we see in that area has to do with state financing arrangements, mechanisms that states use to help fund the state's share of Medicaid payments. At times we see states pushing the limits or working in gray areas to try to obtain federal Medicaid funds, in some cases when they shouldn't be, when it's inappropriate. And those are examples when CMS would need to jump in and take action.
Ms. Riley, what about when a state limits access to care and, for example, children are being denied access to pediatricians or specialists? Have you seen an example where CMS came in and did some kind of enforcement action or exercise their oversight?
I would have to, let me get back to you and ask the staff to make sure that we do a comprehensive review, but there certainly is a CMS oversight.
Mr. Gomez, do you know of an example there?
For speaking for Oklahoma in my 15 years in the Medicaid program, we've never been found in that violation.
Because here's what I'm getting at, and if you all can look at this situation. The end of December, a federal court judge said to the state of Florida that your restrictive networks for specialists and pediatricians, they are so restrictive that you've in effect denied access to care for kids, to medical services. They weighed in on reimbursement rates that are so low that they can't get doctors to participate. During the 8 months in the interim, the state of Florida, rather than stepping up and saying, okay, we're going to rectify the situation, has said, talk to the hand. No, in fact, we are going to continue to limit these networks, and all of the children's medical directors across the state now are in protest because children now are being screened out. They don't have access to specialists. And it would seem that, especially after the Armstrong case by the U.S. Supreme Court, that it really is up to CMS to enforce and step in. I don't know what else these kids can do if they have to rely on federal regulators.
Well, and that is the charge of the Medicaid and CHIP Payment and Access Commission. It's the broad set of activities in which we're engaged, and I'm not familiar with this particular case, but I'm certain that we have a commission meeting coming up, and I can assure you it will be one of the topics we'll talk about.
Kids across Florida would be grateful if the commission would take a look. Thank you.
Chair thanks gentlelady, and now recognize gentleman from New Jersey, Mr. Lance, 5 minutes for questions.
Thank you very much, and good morning to you all. My last name is Lance. I'm sitting here because I'd like to interact with the distinguished panel. I don't know a lot about this issue, but I am certainly interested in it, and I come from a small family law practice where on occasion middle-aged children come into the law practice, my late father and my twin brother who practices law now, wishing to impoverish their parents, and we throw them out of the office. And this is an issue that concerns me greatly. Now, am I right? Did I hear you say, Ms. Riley, that 60% of all nursing home costs are through the Medicaid program?
Long-term services and supports.
And am I right that 37% of all childbirths in this country are through Medicaid?
Well, in Oklahoma, it's about 60%.
60% of childbirths. Now, Medicaid, as I understand it, is a shared program.
Yes, sir.
Costs borne by the federal government and costs borne by the state government.
Yes, sir.
But it's not equal across this country, and it depends on the state. Is that accurate as to percentages?
Yes, sir.
And in Oklahoma, what is the percentage?
It's this October will be 60.99%.
60, roughly 61% is paid by
The federal government.
the federal government. But that certainly is not true in all of the states.
No, sir.
I live in New Jersey, and we pay more than most states. Is that accurate?
I believe so.
And there are states that pay as much as 50%, and New Jersey is one of them. So this is not a program that is equal across the United States. Now, specifically regarding the impoverishment of parents or of a spouse, you're telling me, Mr. Gomez, that the 10th Circuit has ruled that there can be no clawback for annuities? Is that what you're telling me?
Yes, sir. Yes, sir.
Could you explain that in a little greater detail to me? Because this certainly interests me greatly.
Yes, sir. Let me find that note on that particular section.
Take your time. Here in Washington, everybody is in too much of a rush.
The rationale of the court's decision in Morris and similar cases has been extended to other courts, and at least on the 10th Circuit decision to other financial vehicles that similarly thwart Medicaid's intended purpose. So in particular, we've seen an increase in the use of non-assignable, non-transferable promissory notes, but that's not the issue, but the issue of annuities to shelter assets, which the courts have.
And this means that a couple go to an insurance company and give that insurance company $100,000 or $200,000 or $500,000, purchasing an annuity. And then when one of the couple go into a nursing home, there is the claim that half of the marital unit is impoverished and the other spouse can receive 100% of the annuity. Is that what's occurring?
Yes, sir.
And the 10th Circuit said that was legal?
Well, what they're saying is that the court's ruling essentially permits a married couple to shelter a potentially unlimited amount of assets through a non-assignable, non-transferable annuity in order for the spouse of medical need to qualify for Medicare.
And is that based upon the fact that we have not contemplated that here, and the Mullen legislation would rectify that?
Well, let me go back and state, Medicaid statutes allow for a spouse of a Medicaid applicant for long-term care services to keep a certain amount of his or her resources.
Yes, I understand that.
So the amount, the spouse of the applicant is referred to as community spouse, the institutionalized spouse. The amount the community spouse is allowed to retain is called the Community Spouse Resource Allowance, CSRA. So in general, Medicaid will divide that couple's total resources in half to determine the CRSA. What the 10th Circuit said is that money can be diverted in that where the spend down, it can be achieved and still protect the.
Thank you. I'm sure this is not a large problem in the number of persons who utilize this loophole, but I certainly think that it should be closed and closed pronto, and I commend Congressman Mullen in his efforts. And I think it's the purpose of the law not to permit this type of diversion, and I certainly think that it borders on fraud and, in my opinion, is immoral. Thank you, Mr. Chairman.
The chair thanks the gentleman. And now recognize the gentlelady from Illinois, Ms. Schakowsky, 5 minutes for questions.
Thank you, Mr. Chairman. We had talked about that personal care services may be an area that's vulnerable to fraud, and we must make sure that beneficiaries are receiving the services that they need at the right time in the right way. However, I have concerns about a penalty on the state's FMAP in an environment with Medicaid where Medicaid programs really are struggling right now administratively. So, Ms. Riley, I know that MACPAC has not extensively studied this issue, but the Commission has looked at Medicaid administrative infrastructure. Could you tell us what are some of the challenges that are being faced in this space?
In the verification space? I think the states have an array of activities in which they pursue, and I think the notion of electronic validation raises questions about the cost of that. It's, again, the cost-benefit trade-off. I think there are 9 or 10 states that currently have those systems. They have said that they are succeeding in getting savings from those activities, but we're not aware of any evaluations that have been underway or completed that would tell us really what the cost-benefit analysis of that verification activity is.
Well, that's what I'm concerned about, because if the state doesn't implement the electronic verification system under this legislation that's being considered, they face a cut in their Medicaid reimbursement, but there aren't any startup funds or implementation funds before the penalty begins to go into effect. So is it possible that when states spend Medicaid dollars to build these systems, they're going to need to decrease the spending that they have on services? You basically said, I mean, what is the trade-off?
Well, it's obviously a laudable goal to make sure that we root out any fraud and abuse in this very important area. It's a $16 billion spend. The elderly and people with disabilities depend on these services. That said, I think it's a good example of one of the issues that MACPAC has raised in one of its reports. We pay fraud and abuse and fraud control units with a 75-25 match, but we pay for the activities like EVV with a 50-50 match. So they're not startup funds, and there's a sort of a disincentive to do the front-end activity with a lower match rate, but a higher match rate to go get them when there's a mistake or fraud has occurred. So I think it raises an important question that MACPAC has raised in issues about whether we ought to invest differently in state administrative functions that could better prevent fraud and abuse.
So is this decision-making underway right now at MACPAC?
It was a recommendation from MACPAC in I believe our March 2012 report, and a discussion that we've had numerous times with the states. It's really frustrating that one wants to do more to prevent fraud and abuse, and that enhanced match could, of course, that's a cost to the federal government, so that's easy to talk about and difficult to do. But I think it's, again, a balancing act of how much to invest after the fact to go and recoup from fraud and abuse practices versus before the fact to try to prevent them. And EVV is a good example of such an initiative.
So how can we get at a real cost-benefit analysis then?
I think it would be useful. There are the 10 states like Oklahoma that are now engaged in EVV, and I think it would be a fairly quick kind of study, and I'll certainly speak with our staff about whether we can take a look at that.
Okay. I do want to go back to this issue that was raised by Representative Castor about the issue of the treatment of lottery winnings and other lump sum income. I mean, you spoke to it a bit. I mean, it's one thing to talk about a lottery winner and, you know, millions of dollars or whatever. But it really does lump, if you will, together these other things. And you actually raised the issue of disability. I'm really worried about that, that, as you pointed out, that disabled individuals frequently have to wait a year or more, you mentioned, to use, for their application to be processed for disability. And that's after the mandatory 2-year waiting period. And generally, they're paying for all their living expenses and medical bills during that time. So if they're eventually determined to be eligible for SSDI and then get a lump sum payment to cover that waiting period, but that then deprives them of the Medicaid benefit, then how are they to pay back all the expenses that they had while they were waiting?
I think that's a question in the drafting of the bill about how broadly one defines lump sum.
I mean, I just think that putting those two things together, that there ought to be, you know, I totally get if somebody strikes it lucky and gets the lottery, but I'm over my time. Thank you.
Chair, thanks, gentlelady. Now recognize the gentleman from Florida, Mr. Bilirakis, 5 minutes for a question.
Thank you, Mr. Chairman. I appreciate it. Commissioner Riley, all U.S. territories have Medicaid programs, but unlike the states, they have different rules that govern their Medicaid programs, such as eligibility or payment rules. Can you briefly talk about how their program may differ from the mainland? If you think CMS should provide this type of information on a central website like they do for the states?
Again, Congressman, we haven't taken a position on this, but the MACPAC has long been a supporter of good, consistent data from all the states and territories. I think this bill includes the same sorts of information states now must report. So it is very much related and would be consistent with what states now have to report.
Thank you, thank you. According to Puerto Rico's resident commissioner, the Ways and Means Green Book used to have a chapter on social welfare programs from the territories, such as Medicaid. However, that chapter has been removed because the Nonpartisan Congressional Research Service, CRS, could not find enough publicly available information to keep it accurate and up to date. Commissioner Riley, MACPAC is the nonpartisan legislative branch agency that provides Congress with policy and data analysis for Medicaid and CHIP. If Congress needs information to make policy decisions, for example, if the ACA Medicaid funding for Puerto Rico will be entirely spent before 2019, what does MACPAC have to do to find information on the territories to carry out your advisory role?
That's a very good question. We have a wonderful staff who provide detailed information to us, and we can certainly take a look at how much we report on the territories.
Thank you. Please get back to me on that as well. Mr. Hagg, do the territories have the same Medicaid data reporting requirements as the 50 states and the District of Columbia? If so, can you think of a reason why CMS would not include the same information about the territories as they do for the 50 states and D.C.?
I believe they do have the same reporting requirements, and no, I can't think of a reason why it couldn't be shared.
Okay, good. Mr. Hagg, again, I know that you don't take positions on pieces of legislation. I understand that. But in general, does OIG typically favor a greater transparency?
Yes.
In general,
yeah. Yes, in general, more transparency is better than less.
Very good. Thank you. I yield the rest of my time to Representative Guthrie.
Thank you. Thank you for yielding. I just want to clarify a question just before. One of the questions was about the cost of EVV programs and on the states. And my legislation mandates providers use EVV. It does not mandate that states purchase or spend anything to create its own program or moving forward. The disparity between EVV and fraud system is not a disincentive at all, and states should still have an incentive. And there are already people out there that are doing EVV, and the states aren't building a program, aren't setting up a program that's not separate and distinct. There are people currently doing it, so it wouldn't cost the states money. I just want to clarify that point. Thank you.
Chair, thanks, gentlemen. Now recognize the gentleman, Mr. Butterfield, 5 minutes for questions.
Thank you very much, Mr. Chairman. Thank you for holding this important hearing today. Thank you to the witnesses for your attendance. Mr. Chairman, several weeks ago, we all celebrated the 50th anniversary of Medicaid. It was a great day. The benefits of Medicaid cannot be overstated. More than 72 million Americans rely on this program. 75% of children who live in poverty in this country depend on Medicaid. Greater than 10 million school-aged children who live in poverty depend on Medicaid. I represent, Mr. Chairman, one of the poorest congressional districts in the country. More than 1 out of every 4 people in North Carolina's 1st Congressional District lives in poverty. 1 out of 3 of our children live in poverty. Medicaid is absolutely critical to my constituents. It is especially important to children in eastern North Carolina. As a child, I graduated from high school in 1965, the year of the enactment of Medicaid, and I recall as a child, as a high school student, none of my classmates ever received any type of medical treatment or dental treatment because they couldn't afford it, because 90% of our school students lived in poverty. Democrats on this committee have done our part to strengthen Medicaid. I want all Americans to understand and appreciate the importance of Medicaid. The Affordable Care Act, which was drafted by this committee, it actually strengthened Medicaid. I remember the debate so well. It has strengthened Medicaid integrity by requiring regular risk-based screening of providers and suppliers. The ACA increased termination authority to ensure that malicious actors cannot participate in the program. And so it is abundantly clear that the ACA improved the integrity of the Medicaid program across the board. And so I'm interested in hearing more today about how to ensure that the ACA termination requirements are upheld. We want to uphold those in each and every state. I'm also interested in protecting Medicaid beneficiaries from potentially harmful changes to eligibility. Mr. Haig, Director Haig, thank you. The integrity of the Medicaid program is critical to ensure that beneficiaries are not taken advantage of. It is important that the federal government and our states work together to ensure Medicaid beneficiaries have access to care, reliable care. Can you describe, sir, whether the ACA strengthened the law to prevent providers terminated for cause from operating in other states?
It did, yes. There's a requirement that if a provider is terminated in one state or Medicare, they're required to be terminated in other states as well. So yes, it's a very good upfront program integrity control to ensure that bad actors aren't able to access state Medicaid programs.
Has the ACA had a positive impact as of this date in reducing the number of terminated providers from operating in other states?
Yes, it has. It's a start for sure. Part of the process, it was CMS's responsibility to try to set up a central data system that would house all the terminated providers that the other states could access. Based on our work, we found various limitations with that current database. We found that based on some testing we performed, there are some providers still that are terminated in one state that are still operating in other states. And we've made recommendations on how to improve that so those things don't happen any longer.
If you know, will the draft legislation that I'm working on in conjunction with Mr. Bucshon address the recommendations made by OIG to further eliminate the participation of terminated providers?
Most of the problems we found would be addressed. The one difference I would point out is we've recommended that providers who operate in managed care environments be required to enroll as providers. I believe the legislation talks about having the providers register with the state and then a process of having the state notify the managed care network if that provider should be terminated. That's a good start. We believe having them enroll rather than register would create that direct legal authority between the state agency and the provider.
All right, and finally, Commissioner Riley, you mentioned in your testimony that federal rules are already in place to prevent providers terminated in one state from operating in others. Are those federal rules as a result of the ACA law that we've been talking about?
I believe that's correct.
And would you agree that the ACA has strengthened the Medicaid program's integrity?
Yes, and I think CMS has restructured and strengthened its work with the states as well.
Thank you. Thank all three of you. I yield back. Yes.
Chair, thanks, gentlemen. Now recognizes the gentleman from Indiana, Dr. Bouchon. 5 minutes for questions.
Thank you, Mr. Chairman. Along that same line, Mr. Hague, we were talking about, Mr. Butterfield's talking about, does CMS require reporting into their system? Because from the information I have at this point, over a year and a half after your recommendation, 4.5 years after the ACA requirement, CMS still does not require such reporting of terminated providers. Is that true or not true?
Yeah, that's my understanding as well. We've made the recommendation that it be required. I think CMS, they said they concur with our recommendations, but then they pointed to information provided to states that talks about being encouraged. It doesn't talk about being required.
Yeah. You probably know in government agencies, if you encourage something and never happens, you have to require it, most likely. I mean, so have they really, other than that, have they given an explanation of why they haven't required it?
Beyond that, no.
Okay. Can you also talk about the challenges that states may have faced in complying with the Medicaid requirements to terminate a provider's participation in their Medicaid program if that provider is terminated for cause from a Medicaid program from another state?
Sure. The challenges are there needs to be a central data set that states can look to determine whether a provider's been terminated in another state.
So really, CMS needs to have a required reporting to a database.
We believe so, yes.
Okay. And in your opinion, does the draft bill address this challenge, some of the state's challenges, do you think?
My understanding, the draft bill makes it a requirement, yes. Again, the one thing I would point out is that we do recommend that managed care providers enroll rather than register.
Understood. And we're also talking about for cause, and so could you give maybe some examples of why a provider would be terminated for cause from the Medicaid program?
Yeah, for cause would be they've committed fraud or patient abuse or some other type of billing privilege that they've abused that, rather than just being in an active biller. That wouldn't be for cause.
Is there quality determinations in there too? Is there
absolutely, yes. I mean, if there's some type of patient abuse or a quality of care issue, absolutely, that would be for
and
cause.
that would be reported to the state. That would be reported to the state or to CMS if they had those issues.
Yeah, if the state is aware of that type of abuse, then yes, if they terminate that provider for cause, they should report that provider to CMS.
Mr. Gomez, could you talk about maybe the process of terminating providers from your state Medicaid program and how that process works in your state?
We have a 30-day without or with cause termination and a 60-day without cause termination.
So, but I'm talking about the process of how do you determine that it's for cause? Who does that in your state, for example? I'm just trying to get.
Well, we have a Medicaid fraud control unit, as each state does, and we rely heavily on them on the determination of fraud. And then we actually have, through our contracting system, the ability to go, if we have a new provider coming into the state, the ability to go look on the database and see if that provider has been terminated in another state.
So, for example, I was a physician before, so I mean, there are physicians that get their privileges terminated at their hospital for a variety of reasons, right? Does that type of information get to the state?
It does. We have an agreement with the licensure boards in order to be able to share that information if there's a licensure issue and be able to take appropriate action within our contract.
Thank you, Mr. Chairman. I yield back.
Chair, thanks, gentlemen. Now recognize the gentleman from Maryland, Mr. Sarbanes. 5 minutes for questions.
Thank you, Mr. Chairman. Ms. Riley, apologize if the topic's been touched upon already, or this question in particular. But I'm interested in the bill that relates to someone converting assets to income through purchase of an annuity, and the proposed change for how that might be handled. I gather that right now there is some protections that make the state the ultimate beneficiary of annuity proceeds in the case where that spouse dies. So there's a way for the state to benefit, but now there's a proposal to, I guess, divide in half the proceeds during the period in which both spouses are alive, one being in the institution and the other being still at home. And I just wondered if you could speak to what you think the incidence of, like, how frequently do you have a sense the situation is even arising where somebody is doing that annuity purchase under circumstances where there's a spouse that's institutionalized, and then within that universe, how often it's the case that the amounts we're talking about would be such that you could argue that they were trying to kind of waste or hide or redirect assets that would otherwise create a profile that would disqualify the spouse from institutional care. And I would imagine as well that if somebody, for the right reasons, was converting assets to an income stream, that if you required that 50% of that be allocated to the institutionalized spouse, you might create a situation where the spouse that remains at home would actually qualify faster for institutional care based on their profile, because there's a reduced amount of income available to them. So then, in terms of the income profile, you might actually be adding someone onto the state's burden who otherwise, because of a smartly purchased annuity, would be able to cover their expenses through that if they ultimately ended up in an institutionalized setting. So maybe you could just comment on some of those issues.
The law currently protects spousal the spouse at home to a max of $119,000 they can protect.
Yeah.
I don't believe there's any data that I'm aware of. We can certainly have the staff look at this, that talks about the numbers of people who would be eligible for this kind of annuity. I suspect it's small. And you are correct, there remain the estate recovery provisions for long-term care, so that the state is compelled by federal law to go after the remaining estates after the death of the spouse.
Right. Thank you. I have no other questions.
Chair thanks the gentleman, and now recognizes the gentleman from New York, Mr. Collins. 5 minutes for questions.
Thank you, Mr. Chairman. I want to thank all the witnesses as well as, we're delving into something, and I do think, regardless of if there's some disagreement, we all do agree no one wants to see the system gamed. As Mr. Vance said, he'll throw somebody out of the office if they've walked into explicitly game the system. But a couple other questions, I may delve into that a little bit, but my question, Mr. Gomez, is on the electronic verification system, that Oklahoma uses that, as I understand.
Correct.
Give me an idea of what Oklahoma would consider the return on that investment. It was an investment to get in that.
We actually had that independently evaluated we've been in the EVV system for a little over 5 years. In the first 3 years of that system, Oklahoma has had a 5-to-1 return on its investment through cost savings and cost avoidance.
That's what I expected, and I guess I would just point out for anyone who's a little bit worried that whether the federal government piece is 75-25 or 50-50, I know if I'm running a state and the return's 5-to-1, I don't even need the federal government to pay any of it. They're smart and they're stupid. And so while we'd all like to see, perhaps if you're in the state, the federal government paying 75%, I don't know of too many things in life that are 5-to-1. And so, Mr. Gomez, I appreciate that. Now, we talked a little bit about annuities. I think Mr. Sarbanes made it sound like if there's an annuity, half of that annuity goes to the community spouse, half goes to the institutional spouse. But isn't it true that in gaming the system, the annuity can give 100% to the community spouse?
That's my understanding, yes.
Right, and that's a big difference. So it isn't like they're buying this annuity and giving half the money to the institutionalized spouse. In fact, the whole way of gaming the system is buying an annuity where none of it goes to the institutional spouse. The community spouse gets all of this benefit going forward, and it doesn't count. I mean, that's how you game the system. So I just wanted to be clear, it was left kind of hanging there that in the annuity, half of that would be going to the institutionalized spouse, and that's not the case. In your written testimony, Mr. Gomez, you also mentioned promissory notes. You didn't really cover that. And I think we know what annuities are, and it's certainly clear how that could be gained. But can you maybe in just a very short time, is there also an issue on promissory notes?
Yeah, I think what we're seeing is as we're dealing with the annuities in the state of Oklahoma, we're seeing the practice then change to a number of applicants using the court's logic to extend that to promissory notes, to where again they're using, it's the same impact. So it's we're able to shelter some of the wealth from that in a way that's not intended.
So I guess it just goes back, you know, there's creativity in the financial world, as we saw with derivatives. That didn't go so well. But, you know, there's hedge funds out there. The minute smart people get together and say, how are we going to game the system, whether it's on taxes or in this case on impoverishing yourself for this, you know, there's a whole folks that make a lot of money coming up with the next financial product to get past the law. And I guess the real issue here is the fact that Congress plays a role. Is that really what the courts ruled? It was almost like saying, we know this is wrong, but if Congress doesn't act, there's nothing we can do.
Correct. That's what the 10th Circuit effectively said.
And I guess, you know, the other thing that came out in the hearing, one of the things about going almost last, you get to hear the other testimony, is some thought, frankly, by the other side, that parents aren't responsible for their kids. Oh my God, the parent won the lottery. The kid might not be on Medicaid. I think it's a fundamental responsibility of parents in the United States to take care of their kids. And if they've got money and wealth, their kids shouldn't be on Medicaid. And if there's a way, because somebody's won the lottery, literally, their kids shouldn't be on Medicaid, we shouldn't apologize for the fact the family's wealthy now and the kids aren't going to be on Medicaid. That's what parents do. They take care of their kids. So again, back to this piece, and we've nuanced the issue of spreading it out over 1 month. But it isn't like you count it, you know, either anyone could buy. If they win $100,000, that $100,000 doesn't count every month for the next 20 years to disqualify the child. It counts now for 1 month. But if you won, you know, a few $1,000s, a state could decide how to implement this. And if they did spread it over time, it might be $100 a month, and that's not going to disqualify the child anyway. There was some insinuation that this one-time winning of $20 million is $20 million, but $20,000 would then disqualify this child from Medicaid for the rest of their life. But if you took $20,000 and you then spread it over 20 years, that's $1,000 a year. Then you spread that over 12 months, you're talking about $90 a month. That's not going to disqualify a child from Medicaid, is it, Ms. Riley?
I don't believe so. I think the example was a higher number, and I think that's the issue with the definition.
Sure, and if it's $20 million, the kid shouldn't be on Medicaid. So I just think, you know, we do have to be careful in our wording, but in this case, as far as I know, it would go back at the states to decide how to implement it. States are not in the business of hurting their own citizens and certainly not hitting children. At some point, at the federal level, we just need to trust the judgments of our elected officials in the 50 states and our territories to do what's right by their folks and not try to, you know, nuance this in a way that, quite frankly, is disingenuous. Thank you, Mr. Chairman. I yield back.
Chair, thanks, gentlemen. Now recognize the gentleman from New York, Mr. Engel, 5 minutes for questions.
Thank you, Mr. Chairman. Thank you, Mr. Green. You know, nobody wants anyone to game the system, and I certainly don't. And I think that we need to crack down if people are gaming the system for sure. But I think we have to be careful not to imply that somehow Medicaid needs to be denigrated because people are gaming the system. Medicaid is something that's very, very important. It's a critical safety net. There's some hostility around here toward it, and I think that we need to point out how important it is. There are 72 million Medicaid beneficiaries. There are many Americans who face economic hardship or sudden exorbitant health care costs. And I want to talk about my state of New York. We've made significant strides in our efforts to reform Medicaid, both in terms of cutting costs and improving the quality of care that patients receive. Governor Cuomo in June announced that over the past year, Medicaid spending per person in New York fell to a 13-year low. And during the same period, the Affordable Care Act allowed more than 500,000 additional New Yorkers to enroll in Medicaid, which is, I think, a significant step in the effort to reduce the number of Americans who are uninsured. New York's also had success boosting program integrity through the use of corporate integrity agreements, and these agreements are extended to providers that have had compliance issues as an alternative to barring the said providers from the Medicaid program and consequently triggering service shortages for beneficiaries. Corporate integrity agreements afford these providers opportunities to improve their compliance and set up mechanisms through which their compliance can be monitored more closely. In 2013, corporate integrity agreements allowed New York's Medicaid program to save over $58 million. That's significant. So, Ms. Riley, I'd like to ask you this. I understand that MACPAC has recommended that CMS disseminate best practices concerning program integrity so that states may replicate other states' successes. Would New York's success, as I just mentioned, using corporate integrity agreements be considered a best practice worth emulating? And more broadly, can you speak to the value of focusing more of our efforts on sharing best practices like the example I've outlined?
MACPAC is very much concerned about that. There's quite a disparate set of activities across the states, and I think the New York example sounds very intriguing. I think part of the problem is we don't have a good definition of what best practices are and what works and what doesn't. So it would be helpful to be able to take that set of, to have a set of criteria against which to measure state activities and then disseminate those that work across the country. And that was very much a recommendation of MACPAC.
So, thank you. So if something works in one state, it may not work in every state, but it may work in many more states.
That's right. And states tend to pick up, it may not work in Oklahoma, but Oklahoma may be able to tweak it a bit so it works better. And that certainly is an experience that we've seen in MACPAC.
Thank you. My second question concerns H.R. 1771. Mr. Sarbanes, I think, referred to it a little bit. It would modify the manner in which spousal income purchased through an annuity would be considered in evaluating eligibility for nursing home coverage. And let me, Ms. Riley, go to you again. I know that MACPAC's done a lot of work regarding long-term care in the U.S., and is it accurate to say that Medicaid provides the sole form of long-term care insurance in the U.S. today?
It provides 61% of all long-term care coverage.
Thank you. So as a follow-up, can you speak to the importance of protections against spousal impoverishment in states with high costs of living, like New York? Might this legislation have the unintended consequences of leaving a community spouse with very meager resources because she happens or he happens to live in a high cost of living state like New York?
Well, I think that's always a question in these adjustments about the difference in cost of living across the country, and that's a very legitimate question. Obviously, today states are spouses are protected up to the limit of $119,000. It is interesting to think about the unintended consequence that could occur if this bill passes, and that would be to wonder if people would stop buying annuities and then maybe become eligible sooner. It's a question without, I think, an answer at this point.
That's something we should look into.
I think always the unintended consequences are the most difficult to contemplate, but need to be considered.
Thank you very much. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. Now recognize the gentleman from Virginia, Mr. Griffith, 5 minutes for questions.
Thank you, Mr. Chairman. Thank you very much for holding this hearing. As always, these hearings are very enlightening, and I came in today without any questions related to annuities and long-term care insurance, and now I have all kinds of questions. But let me say this. Ms. Riley has indicated, and I didn't look it up, but she's been in this field for quite some time, and the hope had been that long-term care insurance would help offset some of what Medicaid is having to pay. Folks are going to look at the money when you're talking about putting a loved one into a nursing home. They're going to look at this as a tax avoidance situation as opposed to tax evasion. A lot of folks today have said, you know, this is immoral or nobody wants to game the system. the people are going to find a way to hang on to their assets if they can. And one of the things we have to be careful of, and Mr. Chairman, we may need to have a roundtable discussion amongst our members. We have to be careful that we don't go too far in a direction, because people are going to figure out a way. And one of those ways is to go through a divorce, as long as the spouse who is the spouse in the nursing home or incapacitated in some way needing the care is competent, because they want to pass assets on to their children. They're going to figure out a way, and if that way, the only way left is divorce, they'll reach a property settlement agreement, they'll transfer all the money to the healthy spouse, and then the healthy spouse will start working on ways to get that to the children. People will do that. So this is a complicated issue. It's not one where we need folks on each side of the aisle pointing the finger at the other side of the aisle. We need to see if we can't come up with a new paradigm, a new way to do this. I don't have the answer, Mr. Chairman, but I've heard a lot of concern and a lot of issues in regarding promissory notes, et cetera, annuities. But we need to figure out a way that we can make it so that it's affordable for the average American family to have a loved one in long-term care without losing everything they've worked for 45 or 50 years, and they're going to want to pass it on to their kids. So as long as even the capacitated party is competent, they're going to figure out a way. And they're going to game, if we want to call it gaming the system, they're going to game the system, because in the long term, it's better off for their loved ones. And so I don't know the answer, but let's not think there's a quick and easy solution. And I think, Ms. Riley, you would agree with that.
Yes, sir. I think there is some good news, and that is if one is concerned about the spending in Medicaid on long-term care. When I started in this field, Medicaid spending for long-term care was about 75% of the total bill, as I recall, and so that, we have improved economic conditions, improved income supports for older people. Some use of long-term care insurance has changed that situation.
And Mr. Hagg, I got off on that. What I was really going to ask about was, in your written testimony, the OIG has a body of work related to health care provider taxes and how that impacts Medicaid programs. I have a bill in that would do some lowering. The President's Fiscal Commission recommended eliminating the use of provider taxes for providing for non-federal share of Medicaid funding. Can you just discuss that issue in the minute and 40 seconds I have left? 37, 36.
We've done some recent work involving healthcare provider taxes. In one state we looked at, what we saw was a healthcare provider tax, and one that didn't follow the existing rules that are in place, making it, to us it looked like it would have been impermissible. In talking to the state about it, the state said, they disagreed. They didn't think it was a healthcare tax at all. They just said it was a general gross receipts tax, and therefore those federal rules did not apply. We issued a report to CMS. CMS responded by saying they agreed with the position we had taken, but they felt like they hadn't done a good enough job of providing clear guidance to the states on what was expected. So I think sometime about last year, they put out a letter providing that guidance, and at some point we plan to follow up at the appropriate time to make sure that guidance is now being followed.
Well, I think we need to do something. Virginia historically has tried to follow the rules, but for those states that have done other things creatively to figure out ways to make the finances work for their states, they've eaten up some of the money and really put Virginia at a disadvantage. And so Virginia has consistently rejected a so-called bed tax, but many states have that. We think that's other states gaming the system to our detriment, and so we'd like to see it be a level playing field and everybody know what the rules are. So thank you for your work on that. With that, Mr. Chairman, I yield back.
Chair, thanks, gentlemen, and now recognize the gentlelady from Indiana, Mrs. Brooks, 5 minutes for questions.
Thank you, Mr. Chairman. To the panel, thank you all so much for being here and for helping us understand these complex issues. I'm a former United States attorney, and so I've worked with my state's Medicaid Fraud Control Unit. I think we called it MAFUCU as the acronym that I recall. It's been a few years, but I understand all too well the nationwide prevalence of the problem of Medicaid fraud. And I'm encouraged by the fact that the committee is taking up the issues of program integrity. I also am very pleased that Chairman Pitts has introduced, and I'm working with him on H.R. 3444, the Medicaid and CHIP Territory Fraud Prevention Act, because it is important that our territories also have Medicaid fraud control units, and want to dive into that a little bit further. Can you, Mr. Hagg, really just talk with us, and I know Chairman Pitts started out by talking about the units and how they are funded and so forth, but can you give us, based on your experience with the fraud control units in the states, can you explain further why this is a wise investment of our federal dollars to make sure that the territories set up Medicaid fraud control units?
Well, in general, yes. I mean, the fraud control units in the states, they're the groups that are primarily responsible for investigating Medicaid fraud. They're also responsible for investigating patient abuse when it occurs in healthcare facilities. Now, we would be supportive in expanding that, their authority over patient abuse. Right now, they have authority when it occurs in a hospital or nursing home. But if patient abuse occurs in a home-based setting, for example, they currently don't have the authority to investigate that, and we think that's something should be expanded. You know, the fraud control units do a great job. They, I think in 2014, had about $2 billion in recoveries, around 1,300 or so in convictions. It equates to about a return of 8.5 to 1. For every dollar spent, they return about 8.5. So we think they're very important groups involved in Medicaid program integrity.
Thank you. You anticipated my next question, which was actually about the amount of recovery that the units, that the Medicaid fraud control units across the country have recovered. And that's $2 billion that is reinvested for other patients. Is that correct? Or how is the $2 billion then, when it is recovered by the government units that recover it, how is that money used?
I'm not sure exactly how that process works, but certainly, yes, it's more money available that can be used to provide legitimate health care services to Medicaid beneficiaries that need the services.
And I think, just to repeat, that was $2 billion.
$2 billion,
recovered.
yes.
Now, how many Medicaid fraud units are there in the country right now, roughly?
There are 50, 49 states and the District of Columbia.
Okay, thank you. And Mr. Gomez, and just can you just share with me the experience in Oklahoma and the work that Oklahoma is doing, some the benefits, and how do states like Oklahoma feel about the fact that the territories don't have Medicaid fraud control units?
Well, I think for Oklahoma, you know, we take a lot of pride in making sure that we have appropriate program integrity pieces in place, and we actually do counsel as states with our territories and try to share information in terms of how to improve the integrity of the system, even if they don't happen to have some of the resources that other states or territories have. So we do a lot of sharing of information to see what we're seeing on certain activities and how can we share that information to strengthen other programs. So what we find in Oklahoma, when we find weaknesses in the program, using technology, we try to fix it in the system so we can prevent that money, instead of a pay and chase situation, preventing on the front end.
And I think that Mr. Hagg brought up, while I initially was more focused on the fraud aspects and the amount of money that would be recovered, I think your point about the Medicaid fraud control units are they actually the primary units investigating patient care issues, Mr. Hagg?
Patient care issues that occur in healthcare facilities, yes.
Okay. And Ms. Riley, any comments you'd like to make based on your experience about Medicaid fraud control units and the patient care issues?
They clearly are an important front line, and they rest in attorneys general offices and work closely with Medicaid programs, and so it certainly seems that the territories could benefit from that kind of support.
And so because the territories don't have these, is that not happening now then? The patient care issues with respect to healthcare facilities, how is that being monitored then?
There are varieties of ways, though, that states look at patient care, not just through the fraud lens. And there are numerous reports and numerous activities of state licensing boards as well as Medicaid agencies that look at the quality of patient care.
Thank you. Thank you. I yield back.
Chair, thanks, gentlelady. Now I recognize the gentlelady from North Carolina, Mrs. Elmers, 5 minutes for questions.
Thank you, Mr. Chairman, and thank you to our panel. And I'll just start off by saying that I have a few questions here, but I apologize for not being here for the full committee. It's getting back to town, being third day back. We're all pretty busy, and I had some other issues I had to take care of. But I want to start, Mr. Gomez, asking you, in the Deficit Reduction Act, so I guess my point is, if I'm asking you a question that's already been presented, please indulge me, because I apologize for the redundancy. But in the Deficit Reduction Act of 2005, implemented new policies that intended to try to close the loopholes related to the use of annuities as a Medicaid planning device. However, based on the testimony that's taken place today and just what I have listened to, it obviously has not achieved that goal. Can you please explain what the DRA did and why that has not sufficiently closed the loopholes?
I think the best way I can explain it is the relevant findings of the 10th Circuit Court, where we took this issue from Oklahoma. So couples can purchase a qualifying annuity payable to a community spouse without affecting the institutionalized spouse's eligibility for Medicaid benefits. So couples can purchase the annuities as a lawful spend down of the institutional spouse's resources. The court will only limit transfers made to community spouse after the applicant has been deemed eligible for Medicaid assistance. So it allows for the unlimited transfer of resources before the applicant is approved. The DRA actually was trying to have that 5-year look back, and this is a way to get around that.
Okay, so along the line, in the discussion again on annuities, 2014 GAO report of elder law attorneys told the GAO undercover investigators that annuities could be created quickly and thus are a tool for last-minute Medicaid planning. Right. Is this something that you have seen in Oklahoma? And typically, how many months elapse between the creation of an annuity and the submission of the Medicaid application?
Please allow me to get back with you on that length of time. I don't know, but we'd certainly happy to get that back for the record.
Ms. Riley, do you have a comment on that at all?
I don't, but we'd be happy to look at.
Okay, that would be great, because I think that gives us a little bit better perspective when we're talking about timelines. Mr. Hagg, your office, OIG, has a long history of raising serious concerns on waste, fraud, and abuse. Involving personal care services, and having the discussion. I was listening very closely to my colleague from Indiana in a very, very interesting conversation there. You've already made numerous recommendations to CMS. What actions have CMS taken in response to your recommendations, and how can the legislation that we're discussing here today really help to fulfill some of the goals that haven't been met?
Yeah, involving personal care services, we've made a number of recommendations. I think CMS is generally in agreement with those recommendations, that more guidance is needed, that maybe more uniformity is needed. I think there's maybe a disagreement in how you go about doing that. Because of the limited federal rules that are there now and all the problems we found, we felt like a regulation was needed to really spell out what the federal government is looking for. I think CMS doesn't want to go that far, and maybe that's part of the problem with whether the recommendations have been implemented or not. Certainly, with the problems we found, electronic verification would, I think, address some of those issues. Not all of them, but would address some of them.
Great. Well, thank you very much. And like I said, this is a really important hearing for us, and we really do appreciate your input on this. And hopefully, we'll be able to craft that legislation in the manner that will make some real hurdles and improvements. So thank you. And Mr. Chairman, thank you again. And I yield back the remainder of my time.
Chair, thanks to the gentlelady. That concludes the questions to the members. The members will have follow-up questions. We'll send those to you in writing. We ask that you please respond promptly. This has been a very interesting, very informative, and excellent hearing. We thank you for your testimony, and we look forward to working together on behalf of the people to address these issues that we've heard about today. I remind members that they have 10 business days to submit questions for the record, and members should submit their questions by the close of business on Friday, September 25th. Without objection, subcommittee is adjourned.